We're going to press on now and hear from the WHO. What is its action plan for the future? And let me introduce you to Arun Nanda.
Good morning, everyone. I now begin to understand what our Director General, Dr. Nakajima, felt when he followed Dr. Mala as the Director General. It was a hard act to follow, and I can assure you this is going to be an even more difficult act to follow. I've seen Hans before. I've seen him on TV. I've seen him on many different occasions, and he is a difficult act to follow, but I'll do my best. Can I have my slides, please? Oops. How do I find my presentation?
So you will just click on the clicker and it will
Sorry.
and you will see
Okay.
your presentation.
Right. First of all, I stop reading and I'll start to at least imitate Hans. So, first of all, apologies from our regional director, Susanna Jakob. I'm trying to look like her. She sends her apologies, and she sends her apologies because she is really sad. She was here when this conference first took place in Kalinska Institute in 2008. She's also the director who set up the European Center for Disease Prevention and Control, the so-called European CDC, which was in, of course, the Kalinska Institute in Stockholm. So she loves Stockholm, and she's sorry that she's not here. I'll do my best to represent her and to follow Hans. Oops. Just a bit about WHO and who I am in reference to WHO, which is that WHO is uniquely a decentralized UN specialized agency. We have 6 regional offices dotted across the world, and we have 152 country offices. So we're unique in the sense that we actually have our foot in each and every country. I myself come from the European office, and the European office is actually covering 53 member states. And Europe, for us, stretches from the north to the south and from the east to the west. It's a region which is very diverse. It's very complex. But Europe's diversity, we regard it as an asset and a challenge at the same time. An asset because we can learn from all our 53 countries, and a challenge because their needs are so different. Just to show you diversity in numbers, if you take the World Bank and you take money, Hans's favorite commodity, you will see that we cover all the 4 dimensions defined by the World Bank in terms of lower, middle, and upper income times. What I'll try to do is start with a bit about health as a global good, and then go on for governance to health, and the topic that our moderator right at the start said, MDGs and post-MDGs. First of all, just to start with what is health as defined by the WHO Constitution, and here I'd like to say that WHO is an organization which is of its member states. So don't regard WHO as the Secretariat, don't regard WHO as me, but regard WHO as me and you, the Secretariat and the member states. And that gives us a democratic organization, and an organization that is actually powerful in the sense that it represents and is part of you. In our constitution, our forefathers, who were a lot smarter and formed the organization just about when Hans was born and about when I was born, and they defined health not as the absence of disease or infirmity. And if you remember Hans's graphs, at that time, that's what the world was about. So already they were thinking that health was something more than that. They were aiming for exactly what Hans has further on shown that we have come to enjoy, and that it was a fundamental human right. In 1977, under Dr. Mala, WHO came up with a historic resolution, in my view, which was called the HFA resolution, where it defined that the main social target of government and WHO should be a level of health that permit people to lead an economically and socially productive life. Health is not only for health's sake, it's also good for the economy. I hate to contradict Hans a bit, but it's good for the economy. If you are healthy, your economy approves. And the World Bank actually joined WHO in 1992 with its World Development Report, which actually changed the whole direction of saying, because in the past was improve your economy, health will improve. They said no, improve health, it helps the economy. There are many definitions of global health. I will not dwell on them, but you can see that there has been from 2006 onwards. And maybe we've come full circle, because the latest definition I read, and I think it was in the Lancet or it was in BMJ, I can't remember now, but it is that global health is public health. So we're back really where we start. What has happened in the last few years of my life as working in health is that I've seen health go higher on the political agenda. I have seen in the country I know best, which is the United Kingdom, I have seen the Department of Health move, and those of you who might know London, it moved from Elephant and Castle to Whitehall. Whitehall is where the real business of government takes place. Elephant and Castle is somewhere else. And that shows that health has become more important, because when Mrs. Thatcher started to have a lot of questions in Parliament, what tended to happen was that we were running from one end of London to the other, and we were caught in traffic jams. So for many years we were trying to get to Whitehall. We didn't succeed, but she helped us get there. It's also an important global economic and security issue. I do not have to remind you of SARS. You know how much that cost. You know the panic across the world. It's a major investment sector for human, economic, and social development. You've seen the example of pharmaceuticals already. It's a major economic sector in its own right. In many countries, health is the major employer. And of course, human rights and social justice, Hans has explained more than I can. What has happened also that the health landscape has changed dramatically. It has become more extensive, more complex, yet, as Hans has pointed out so graphically, and I can't, there are deep inequities that remain. And those inequities we really have to tackle. And the health challenges have become much more multifaceted and require the active involvement of all levels of government. And this is what I shall push throughout this presentation. It's not the health sector alone can solve the health problems of the world. It's all the sectors that have to combine and contribute it. This is also inherent in the MDGs, and I hope very much will also be in the post-2015 criteria. I won't go through the boxes. By the way, before I forget, the presentation with quite extensive notes is available. Everybody is welcome to have a copy if they need. Just to show the complexity, and again, there's no point, the slide speaks for itself, but I only would like to emphasize that the recent issue of food safety, and in actual fact, the labeling of food, whether beef is beef or pork is pork, is also a matter of concern, because the public's perception, your perception of your confidence in the food system, in the confidence of the government that provides that, will also be dependent on the messages that we give in health. So if you say that this food is good for you or this food is bad for you, you'll say, all right, the same bloody people who told us that beef was beef. So what is WHO's role in this changing world? WHO, we are going through reform. Everybody goes through reform. WHO is also going through reform. Perhaps it's overdue. After all, it was 1948. But still, it's interesting that nobody wants to change the WHO constitution. And as somebody once very rightly said, if there wasn't a WHO today, then we'd have to invent it. There are 6 core functions of WHO. They were actually set up in what we call our global program of work. And it was the 11th program of work 6 years ago that these 6 core functions were articulated, and actually they are still reaffirmed today. And the architect for our 11th program of work is in the audience, Dr. Nostrom. And I would hate to to comment on any of those, given the architect is here. But what is new, what we've done in the reforms, and the member states have forced us to do it, and really it is quite unique, that we have actually for the first time articulated and specified the roles and contributions of the 3 different levels of WHO. So we specified what the global level will do, what the regional office will do, and what the country offices will do. This is all very well, but how do we turn policy into concrete action? And here there are a number of different things from the roles that you will see. They are hard instruments. For the first time, WHO has got legal agreements which can actually be enforced. So we have, as you know, the Framework Convention on Tobacco Control, the importance of which Hans has already pointed out, and of course the international health regulations, because we cannot ignore communicable diseases. We are we are one species fighting against another species, and this fight is not a short fight. This fight is forever. They are trying to survive, and we are trying to kill them. So it will continue, and the international health regulations is terribly important in keeping the health across the world safe. And then there are soft instruments, and I'll go more about these. I've already talked of the Health for All policy. There are the Millennium Development Goals globally. There's the UN Declaration on NCDs, and the importance and the need for the NCDs, of course, Hans has again pointed out. And then I'll come to what we do in Europe, and we have the new policy, Health 2020. So a bit about the Millennium Development Goals. As you know, there are 8 MDGs. They were to achieve by the year 2015. There are 3 specific health-related MDGs. Reducing child mortality, improving maternal health, combating the 3 main communicable diseases plus others. But importantly, as Hans has pointed out, health also contributes to many other MDGs. Most importantly, poverty, as he so clearly pointed out. There's been a process of looking at what we call Rio Plus 20, the future that we want, which is talking of the time after 2015, and they're talking of sustainable development goals. This is a long drawn-out consultation. It's an open working group of 30 representatives nominated by member states. WHO is fully involved in the process. There's a health thematic group, and there are a number of guiding questions. I won't go through them, but you'll see them on the presentation. There are some strengths and weaknesses of the existing health MDGs. Most importantly, as you can see, and I'm sorry I don't have the strength to use the pointer, and I don't know if this has a pointer, but you can see the highlighted thing, that the most important one that is missing from the existing MDGs that the health people have been fighting for is that there was nothing on non-communicable diseases, the main killer in Europe. Certainly in Europe and across the world, as Hans has pointed out, now what we have not realized in Europe, but is true in many other countries, is that there's the double burden of disease, the so-called double burden, and that is you have communicable disease and non-communicable disease. The old MDGs concentrated only on communicable disease, and now the argument is clear that we need to also include non-communicable disease. We are talking about the different goals for what are the possibilities and options for post-2015, and in the group, there are 3 main goals that seem to have the most support. There is maximizing healthy life expectancy, as was shown at the early start of Hans's. Then what we, at least in WHO, are more keen on in universal health coverage, and the arguments are clear, as you can see already from what Hans has said. In fact, I didn't have to say a lot because he said much of what I wanted to do as the basis for that. And then a set of MDG-like goals. The most important thing is equity and human rights remain as central elements. These will be debated in the forthcoming World Health Assembly in Geneva in May this year. I won't go through this, but this is just to tell you that what are the arguments for an exchange, what are, for the different ones. There's maximizing health coverage, universal health coverage. Now I'd like to come to Europe, the topic that I'm more familiar with because I come from the regional office. I'm sorry, I also compartmentalize slightly. First of all, we have a new health policy for Europe. It's called Health 2020. It builds on the previous policies of Health for All. It builds on much of the work that we've done, including the Untitled Chapter, which was in 2008 and was concentrating on health systems. But why are we having Health 2020? As Hans has pointed out, yes, health has improved. As he's also pointed out, the improvement is not equal. This is just as true in Europe. It's just as true in Sweden, if you look across the different parts of Sweden, as it is in the rest of Europe and the world. We have a changing landscape. We have new challenges, new opportunities, and there are also new threats. And we need to champion public health. Public health for the last 10 years or 15 years has been neglected in Europe. And we are trying to bring it back as a central theme, and I'll explain why in a minute. So what is Health 2020? It's a value-based, action-oriented, evidence-based policy framework which you can adapt, or all member states can adapt to their different realities. They don't have to take the whole policy. They don't have to take one specific part or whatever. They can choose what they like. The policy is built on the evidence, not only the epidemiological evidence, but also the solutions, the options that different countries are taking across Europe. So it's building on the experience of all our member states. It's addressed to ministers of health, but also to engage the other ministers, the other sectors. As I said, we are going for a whole of government. Most importantly, what is new, we are going for a whole of society approach to improve health and well-being. So, Health 2020, we worked 3 years together with our member states from 2010, and last year in Malta, the regional committee approved Health 2020 policy. And as I said, it was to significantly improve health and well-being and to reduce health inequities and to ensure sustainable, people-centered health systems. I was reflecting on this when Hans was showing his pictures with the patients. That's perhaps the most important, which we sometimes forget. There are 2 documents of Health 2020. There's a short document. It's aimed directly at the ministers of health and also to ministers in related sectors and to prime ministers. Then there's a longer document which is primarily for policymakers, public health professional researchers. To me, the longer document is the Bible. It is the document that one can go to if you want to see what is the solution for a particular problem which somebody in Europe is using and implementing in some way. So it's a living document. It's on the web, and it will be updated on a regular basis with new experience. So really, well, to me, that's the one that's more important, though frankly, to move things forward, perhaps the short document is even more important. What does Health 2020 have? It's got 2 strategic objectives: working to improve health for all, so to reduce inequities, to improve the leadership and parts of the governance for health. Health 2020 has 4 common priority areas for health. Again, it's about life course. It's about reducing and tackling Europe's main health challenges, which are both NCDs and communicable diseases, and to strengthen the health system, to make it people-centered. And perhaps most importantly, also for well-being, is to create resilient communities and supportive environments. These are the settings. These are to have healthy cities, to have healthy environments, to have environments which are conducive to health, education, Hans has mentioned. So there are many in that area. The policy, as I said, is not only based on the experience of the member states and what is happening in member states, but we actually commissioned some studies. So we commissioned 2 studies on governance. What does it mean, the whole of government approach? What does it mean, health in all policy? What are the new developments? And there are 2 studies here done by Professor Ilona Kickbush. She was the one who was also here with Dr. Nostrom when you had the conference in 2008. And then there are a study on the economic case for prevention. Most politicians think that prevention is something where the returns would come in 5 years or 6 years. No politician is really interested in waiting that long. They want change that they can contribute, that they can identify with. All the new evidence suggests that there is a shorter time scale in prevention and the effects on health. And this is something done together with OECD. Then there is the fourth one, which is intersectoral governance for health in all policies, which actually, as you know, Finland also promoted in the EU presidency, and in fact in the new health promotion conference that's going to take place later this year, this will be a theme that will come back. And then there's the famous report which is going to just about to come out, which is by Professor Michael Marmot. I'll talk about it in a bit more in a minute, which is about, we all know that social determinants affect health. And this actually gives you a bit more about that. And then we've also looked at our so-called resolutions. WHO, World Health Assembly comes up with resolutions. I quoted one. So and it also asks for commitments of the WHO member states. And we've done a review to see how many of those are effective or not effective and where they are. A bit about Michael Marmot's study. It proves and shows that most of the inequities in health between and within countries are socially determined. That a life course approach to health is very important to health equity. Hans has given classic examples of that. It's education, it's early intervention, it is the adolescents' early years which influence healthy lifestyles or not healthy lifestyles. It's also during the workplace what happens. I hate to point out, but in actual fact, as women are entering the workforce, they're picking up the bad habits of men. So what is happening is that the God-given protection to women is actually being eroded by their lifestyles. Yes, smoking is going down in Europe, but smoking is rising in women. And all you have to do is look at the lung cancer rates for women, and you will see that in Sweden the lung cancer rates are going up, as indeed they are in Denmark, as they are indeed in Norway, as indeed they are in Netherlands. The graphs are quite dramatic. I hope Hans will include them in one of his later presentations. Here, all I like to say that the conclusions of Sir Michael Marmot's study was, those who are doing nothing, do something to tackle social determinants. Those who are doing something, do more. And those who are doing a lot, like in fact in Sweden, do it better. So Health 2020 is all about going upstream, tackling the root causes, including public health, so using public health, health promotion and prevention, and making the case for a whole of government and whole of society approach, because the health sector cannot do it on its own. I won't go into that. That's a study to show improving governance for health. And I'll start to be out. What Health 2020 has done is actually put public health more firmly in the frame. And along with approving the European health policy, Health 2020, the member states also improved an action plan for strengthening public health capacities and services. And this built on the Tallinn Charter, which will be reviewed later this year. Just to tell you a bit about what the action plan is, we've identified 10 essential public health operations, what we call. These are not new. The CDC did it about 10 to 15 years ago, if I remember correctly, and they also identified what are the key public health functions. And we've tried to amplify these, and we have a little assessment tool which allows member states to evaluate just how far ahead or not they are in the essential public health operations, so they know which ones to concentrate and to strengthen further. Here I'd like to just pause for a minute just to show you that communicable disease are just as important in Europe as they are anywhere else. This is multidrug-resistant tuberculosis. The top 15 countries in the world with MDR-TB are in this region. And don't think they're only in the Eastern Europe. There are also EU countries which are on this list. Most importantly, if you look at the first column, you'll see that there are high percentage of new cases, not retreated cases, but new cases. What it means is that MDR-TB is endemic in our region. So we developed action plans not only to cover MDR-TB, but also to cover HIV, which is also rising in Eastern Europe, fueled by injecting drug users, and antimicrobial resistance, because if we lose the ability for antibiotics to work, we are really back in the ages when Hans and I were born. Some good news, along with bad news. We are close to eliminating malaria in the region, and we are still polio-free. And we are polio-free for the simple reason that polio actually is a worldwide problem. We are close to eliminating it in the world, but it re-entered Europe. If Europe loses its polio-free status, all of us are affected in Europe. And we made a major effort, and we actually contained the polio in 2010 when it entered. Measles and rubella, unfortunately, is a Western European problem, remains so. NCDs, I don't need to go through this. This is looking at the same data that Hans has looked at. But I would like to dwell for just a little bit on the economic burden of chronic diseases. You will see that there is a huge economic effect of all the different diseases. The figures are not small, they are huge. So there is an economic case for tackling NCDs as well. Fiscal policies can have an improvement on health, and these are the figures to show you just how much that change can be. There is, very quickly on austerity. Austerity is a factor in Europe. It's a factor that we need to tackle. We are tackling it, working with the member states, and we will actually discuss this next month at the so-called Oslo II conference on the effects of the financial crisis on health.
Arun, I'm going to interrupt you.
Sorry, I know.
And say thank you very much for laying out the scene for us.
About to finish. I'd just like to end with a quote from our Director General.
Please.
And she said that money does not buy good health. It's good policies that buy good health.
What was that about money? Hans Rüssling, are you listening? It's not just about money. We had set up a little clash there. Thank you very much for putting... No, not at all. So a different view then. It's not just about the very poorest, which we heard about from Hans Rüssling. We hear that there are pressing issues here in Europe with NCDs and communicable diseases like TB for all of us to be very aware of and focus on. Thanks for some great questions, guys. You've given us some really good questions for the debates that are going to follow up later on in the day. And Richard was busy taking them down. Thank you to David from Cold Star, who sent in a lovely question about access to drugs from Facebook. Thank you to Theo Bowden, who sent us a very good question about CDs to NCDs, which we're going to follow up a little later on in the day. Before you go, I want to ask you one question which has come from Blue Morpho. Great name, Blue Morpho. Thank you. What is the comparable advantage of WHO compared to other global health initiatives? How can WHO get more muscles, be more innovative?
Well, to me, WHO is unique in one respect. When WHO can do things and say things which other people don't and can't.
Like what?
I'll give you two examples. Most recent one is when Dr. Lee, God bless his soul, he's dead now, he came up with 3x5, which was to treat 3 million people who were on HIV with antiretroviral treatment by the year 2005. And people laughed. This was the time when, as Hans pointed out, the price of treating somebody was huge and only available to the rich. And his logic was straightforward. If we don't set this goal, if we don't try to achieve it across the world, why should anyone with HIV come forward? To be stigmatized, to lose his job? And we know that in communicable diseases, if you do not bring the disease out, if you try to bury it under the table, it's no good for no one.
So WHO can take leadership on issues like this?
He takes that. Health for all is another clear indication. When we developed the Health for All policy in Europe, member states laughed at us for the simple laughed, actually their fault, because we said that you have to have peace. In order to have health, there must be peace. There must not be war. And they said this is not WHO's business. But we still said it. So there are many examples if you go back in WHO, and it's that. I don't
So
call it a leadership
you're
role.
prepared for people to say, hey, that's rubbish, but we believe it anyway.
But you
and
have
stand up there and be
somebody
counted.
has to start it. And then
And that's your role.
And in a sense, well, it's not the only role. The 6 functions we pointed out, to me, that's the most important role.
Arun Nanda, thank you very much.